Let's jump right in. First up on our list, Parinaud syndrome.
Okay, Parinaud syndrome. So the mechanism, straight from our sources, is lesion in the dorsal midbrain, often due to pineal gland tumors.
Dorsal midbrain, so the upper part of the brainstem.
Exactly, that specific area. And the damage, well, it's frequently caused by a tumor in the pineal gland, that small gland located deep within the brain.
Okay, and what does that actually mean for someone experiencing it? We received a story from a parent about their son, Leo, that really puts this into perspective. They wrote, "My son, Leo, was always so bright and active. But around his 10th birthday, we started noticing something strange with his eyes. When we'd ask him to look up or down, his eyes would just stop. He wouldn't move past a certain point like he was stuck looking straight ahead. We initially thought he wasn't paying attention, but then his teachers mentioned it too.
Right.
The doctors ran some tests, and it turned out he had a small tumor near the back of his brain, a pineal gland tumor, which was pressing on the part that controls eye movement. It was a terrifying diagnosis, but at least we finally understood why his eyes were acting so strangely. His journey then became about treating that underlying tumor."
Wow. And what Leo experienced there, that inability to look up or down properly, is a classic example of a vertical gaze palsy. It's a hallmark of Parinaud syndrome.
Right.
That pineal gland tumor, even if it's small, can compress that dorsal midbrain region, directly impacting the neural pathways needed for those vertical eye movements.
So diagnosis is key, I imagine, like an MRI.
Absolutely. Neuroimaging, like an MRI, is crucial to pinpoint that lesion.
So the key takeaway here, the exam pearl if you like, is that difficulty with vertical eye movements, especially looking up, can be a specific sign pointing towards that dorsal midbrain area, often due to a pineal gland tumor. Such a precise connection.
Very precise.
Okay, next, let's turn our attention to a condition that can escalate. Well, really quickly, cerebral edema.
Yes, cerebral edema. The mechanism is defined as fluid accumulation in the brain parenchyma increases intracranial pressure.
So basically fluid building up inside the actual brain tissue.
That's it, an abnormal buildup. And this significantly raises the pressure inside the skull. You see two main types. Cytotoxic, where fluid gets inside the cells, often from poor blood flow or high ammonia, and vesogenic, where fluid leaks out of blood vessels. That's common with head injuries or tumors.
And that pressure can be incredibly dangerous. We have a story from a caregiver who witnessed a sudden, quite alarming change in their elderly mother.
Okay.
She said, "I was caring for my elderly mother after her recent fall. She seemed okay at first, just a bit confused, but then she started complaining of a terrible headache, throwing up, and her breathing became irregular.
Oh, wow.
Her heart rate was really slow, and she was getting more and more difficult to wake up. It was terrifying, like a switch had flipped. We rushed her back to the hospital. Immediately did a scan. They said fluid was building up in her brain, causing a lot of pressure. They had to act fast to medications like mannitol, raising the head of her bed, just trying to reduce the swelling and save her."
That narrative just perfectly illustrates the critical nature of this. The headache, the vomiting, the slow heart rate bradycardia, and that reduced alertness. Those are classic signs of dangerously increased intracranial pressure, or ICP.
Right, because the skull can't expand.
Exactly. The brain simply doesn't have room to swell within that rigid skull. So an immediate non-contrast head CT scan is vital for diagnosis. It lets doctors quickly see the swelling and start urgent management to decrease that pressure.
It's such a powerful reminder of how rapidly things can escalate and how critical that fast diagnosis and treatment really are. The exam pearl being that fluid buildup, whether cytotoxic or vasogenic, leads to that increased ICP, presenting with those specific symptoms and needing that quick CT.
Couldn't have put it better.
Now let's explore aphasia. This is a condition that affects one of our most fundamental human abilities: communication.
Aphasia. The mechanism from the text is stroke in dominant, usually left hemisphere, in either the superior temporal gyrus of temporal lobe, Wernicke, receptive aphasia, or inferior frontal gyrus of frontal lobe, Broca, expressive aphasia.
So aphasia is kind of a general term.
It is. It covers problems with speech and language that happen when specific parts of the brain dealing with language get damaged. Usually that's on the dominant left side.
And there are different forms, right? Each tells a unique story. Here's one that perfectly illustrates what's known as Broca's aphasia.
Okay, Broca's.
This person wrote, "My grandfather had a stroke and it was so sudden. One moment he was talking on the phone, the next he was trying to tell me something, but the words just weren't coming out right. He knew what he wanted to say. You could see the frustration in his eyes, but it was just a jumble of sounds. His speech was telegraphic, few words, frequent pauses, and he was clearly so frustrated because he knew something was wrong.
Yeah, that awareness is key.
The doctors called it Broca's aphasia. He understood everything we said perfectly well, but speaking was like trying to climb a wall with no footholds.
Yeah.
It was heartbreaking to watch him struggle. But we later learned that speech therapy would be a really important part of his long-term recovery.
That's a classic presentation of Broca's, or expressive aphasia. The damage, typically from a stroke, is in that inferior frontal gyrus Broca's area, often on the left.
Right.
And that area is crucial for producing speech. So people understand what's being said, but they really struggle to form the words or complete sentences. That frustration he felt, very common because their comprehension is intact.
And diagnosis, clinical signs plus imaging.
Exactly. The clinical features point to it, and neuroimaging, like a CT or MRI, confirms the location of the underlying brain lesion, often a left superior middle cerebral artery, or MCA, stroke.
It's just fascinating how specific the brain's functions are. Damage to one area hits expression, but leaves understanding largely untouched. The exam pearl, stroke in the dominant hemisphere, specifically Broca's area, causing that expressive broken speech, but with intact comprehension.
Well put.
Okay, from communication difficulties, we shift to something, well, an even more profound challenge, locked-in syndrome.
Yes, locked-in syndrome. Its mechanism is described as stroke of the basilar artery. Also, massive axonal demyelination in pontine white matter can cause locked-in syndrome.
So a severe stroke affecting the brainstem artery, the basilar artery, or widespread nerve damage, demyelination in the pons.
That's right. Either of those can lead to this state where a person is completely paralyzed, unable to speak, yet fully aware.
It's just an agonizing reality. Here's a story from someone whose uncle experienced this. It highlights a critical and often surprising detail.
Correct.
They said, "It happened to my uncle, a sudden devastating stroke.
Yeah.
One day he was fine, the next he was in the hospital, completely still. Couldn't move, couldn't speak, not even a finger.
Wow.
We initially thought he was in a coma, but then the doctor noticed something crucial. He could blink once for yes and twice for no, and he could move his eyes up and down."
The vertical eye movement.
Exactly. It was agonizing to realize he was fully aware, trapped inside his own body. He understood everything, but the only way he could tell us anything was through those tiny eye movements. We spent hours just asking him questions, watching his eyes, grateful for that small window into his mind. They focused on supportive care, naturally, and finding ways for him to communicate.
This story perfectly illustrates the core of locked-in syndrome. And the key differentiating feature is that preservation of consciousness and vertical eye movements, despite the complete paralysis of other voluntary muscles.
Right.
A basilar artery stroke damages the motor pathways in the brainstem, but it spares the pathways controlling vertical gaze and, crucially, the reticular activating system, the brain's arousal system.
And that's what distinguishes it from a coma where consciousness is lost.
Precisely. The exam pearl is remembering that basilar artery stroke affects those brainstem tracts, leading to paralysis except for vertical eye movements, indicating an intact consciousness.
That ability to communicate, even so minimally. It's just profound. All right, let's continue our journey through the brainstem, now focusing on lateral pontine syndrome.
Okay, lateral pontine syndrome. The mechanism for this one is a stroke of the anterior inferior cerebellar artery, or AICA.
AICA. And that artery supplies the side of the pons and parts of the cerebellum.
Exactly, the lateral pons and parts of the cerebellum. And because of the specific structures located there, damage leads to a really unique combination of symptoms.
Right, a distinctive pattern. We heard from a neighbor about their experience with Mr. Henderson.
Let's hear it.
He said, "My neighbor, Mr. Henderson, suddenly couldn't smile on the left side of his face.
Ipsilateral facial paralysis, a lower motor neuron lesion sign.
And his left eye drooped.
Ipsilateral Horner syndrome, ptosis, meiosis, and hydrosis.
He also started stumbling to the left.
Ipsilateral ataxia and dysmetria from cerebellar involvement.
And kept telling us the room was spinning.
Vertigo and nystagmus vestibular nuclei involvement.
What was really strange was that he said his left ear felt muffled.
Ipsilateral sensorineural deafness, the cochlear nuclei are affected by AICA strokes.
And he couldn't taste anything on the front of his tongue.
Decreased taste from the anterior two-thirds. Facial nerve again.
The doctors explained he had a stroke affecting that AICA artery in his brainstem. The diagnosis was pretty clear clinically, but MRI and MRA confirmed the vascular event. It was a lot to take in, seeing so many different things go wrong all at once, all on one side of his body and face.
It's a striking collection of symptoms, and the exam pearl, the key differentiator here, is really the involvement of the facial nerve nuclei causing that ipsilateral facial paralysis and taste loss, along with the hearing loss and ataxia. That constellation points strongly to an AICA territory stroke.
So many specific signs linked to one artery. Okay, moving slightly down the brainstem, we encounter lateral medullary syndrome, also known as Wallenberg syndrome.
Wallenberg, yes. This syndrome's mechanism is a stroke of the posterior inferior cerebellar artery, or PICA.
PICA. Okay, so this artery supplies the lateral medulla this time and parts of the cerebellum.
Correct, the lateral part of the medulla oblongata. And again, the structures located there dictate the specific set of symptoms you see when it's damaged.
And the symptoms of Wallenberg can be quite pronounced, very distressing. We have an account from someone whose aunt faced this. She described, "My aunt woke up one morning and couldn't swallow. Every attempt to drink water just made her choke, and her voice was raspy like she'd been yelling all night."
Dysphagia and hoarseness. That's involvement of the nucleus ambiguous cranial nerves IX and X. That's a key differentiator for Wallenberg.
Her left eye also looked droopy.
Ipsilateral Horner syndrome again? Possible here too?
She said her left side of her face felt numb to hot and cold, but her right arm felt numb.
Okay, that's classic. Decreased pain and temperature sensation on the contralateral body, but ipsilateral face, due to spinothalamic tract and spinal trigeminal nucleus involvement, respectively.
She also kept feeling like the room was spinning.
Vertigo, nystagmus vestibular nuclei again.
And couldn't stop hiccuping.
Hiccups can happen too, likely due to medullary irritation.
The doctors explained it was a stroke in her brainstem, specifically Wallenberg syndrome. The diagnosis was primarily clinical, confirmed by MRI. It was terrifying, especially the swallowing issue, but knowing the cause helped focus her recovery, which needed specific rehab.
It's a very characteristic syndrome, and for exam pearls, that mnemonic is quite helpful. Don't pick a lame lateral medullary syndrome, hoarseness that can't eat dysphagia. It really captures those key nucleus ambiguous symptoms.
That's a good one. Hoarseness and dysphagia pointing to PICA Wallenberg. Now let's explore medial medullary syndrome, which offers a unique contrast to the lateral syndromes we just discussed.
Right. Switching to the middle of the medulla. The mechanism for this one is a stroke of the anterior spinal artery.
Anterior spinal artery.
Okay.
And that supplies the medial or middle part of the medulla oblongata.
Correct. Leading to a distinct set of symptoms related to the motor and sensory pathways that run through this specific area.
A very particular presentation, as we hear in this story about a grandfather.
Okay.
His grandchild wrote, "My grandfather's speech suddenly became slurred, and when he tried to stick out his tongue, it veered sharply to the right."
Ipsilateral hypoglossal dysfunction. The tongue deviates towards the side of the lesion. That's cranial nerve involvement, a unique feature of medial medullary syndrome.
He also couldn't move his left arm or leg very well.
Contralateral paralysis of the upper and lower limbs. That's the corticospinal tract being hit as it passes through the medial medulla.
And when we tested his sensation, he couldn't tell where his left leg was in space without looking.
Decreased contralateral proprioception. That's damage to the medial lemniscus pathway.
The doctors quickly identified it as a stroke, specifically something called medial medullary syndrome. The diagnosis was clinical and confirmed by neuroimaging, like MRI. It was quite specific, affecting his tongue movement on one side and his body movement and position sense on the opposite side.
Exactly. That contralateral motor and proprioceptive loss, combined with the ipsilateral tongue deviation, is the hallmark. It clearly points to exactly where the problem is in the brainstem.
So the exam pearl. Anterior spinal artery stroke leads to contralateral motor and proprioceptive loss, plus that ipsilateral tongue deviation. Very distinct from Wallenberg.
Very distinct indeed.
Okay, shifting our focus now to our most vulnerable patients.
Yeah.
Let's discuss neonatal intraventricular hemorrhage.
Yes. IVH in premature infants. The mechanism here, from our sources, is quite specific. Reduced glial fiber support and impaired autoregulation of blood pressure in premature infants leads to bleeding into the ventricles, originating in the germinal matrix, a highly vascularized layer within the subventricular zone.
So it's really about the immaturity of the brain in preemies, especially that germinal matrix area.
Precisely. That germinal matrix is a very delicate, highly vascular area in the developing brain, and in premature infants, it's prone to bleeding. especially if there are fluctuations in blood pressure, which their systems can't regulate well yet. The bleeding occurs into the brain's fluid-filled spaces, the ventricles.
It sounds truly heartbreaking for new parents. We have a story about a daughter named Lily that highlights the fragility here. The parents shared. Our daughter Lily was born incredibly early. She was doing well in the NICU, but then suddenly the doctor seemed very concerned. They did an ultrasound of her brain and found bleeding inside her ventricles.
The head ultrasound, that's the primary diagnostic tool for premature infants at risk.
Yeah.
It's readily available in the NICU.
They explained that because she was so premature, the tiny blood vessels in her brain weren't fully developed and were fragile, especially in that germinal matrix. We were terrified when they told us how delicate it was. She became very lethargic, and her blood pressure dropped.
Those can be subtle clinical presentations: lethargy, apnea, bradycardia, hypotension. They can escalate to more severe things like seizures if the bleed is large.
It was a really scary time, but the team monitored her closely, and thankfully the bleeding stabilized with supportive management.
Management is primarily supportive, maintaining stable blood pressure, ventilation if needed, treating seizures. Preventing prematurity is key, of course.
And the example is really that link, isn't it?
Yeah.
This condition is almost exclusively seen in premature infants, connecting prematurity and that underdeveloped, fragile germinal matrix vasculature to these bleeds.
Exactly right.
Okay, now let's turn to head injuries, starting with epidural hematoma.
Right, epidural hematoma. The mechanism is rupture of middle meningeal artery, often secondary to skull fracture, involving the septerion.
Septerion, that thin area of the skull near the temple.
Yes, and the bleeding occurs outside the duramater, that tough outer membrane covering the brain. It's typically arterial bleeding, usually from that middle meningeal artery, often torn by a skull fracture from a head impact.
This injury has that classic and often really misleading presentation that demands immediate attention. We heard about a soccer player named Mark.
Okay.
His friend told us. My friend Mark was playing soccer and took a bad hit to the head. He was knocked out for a moment, but then he came to, seemed fine, even joked about it.
The transient loss of consciousness followed by a lucid interval. That's the classic dangerous sign.
We were relieved, naturally. But a couple of hours later, he started complaining of a terrible headache and got really confused and rapidly became unresponsive, showed that rapid deterioration.
Yeah, as the hematoma expands and pressure builds.
We rushed him back to the hospital. The immediate non-contrast head CT that was diagnostic, it showed a lens-shaped bleed in his brain and epidural hematoma from the impact.
That biconvex or lenticular shape on CT, which doesn't cross suture lines, is characteristic.
The doctor said that initial lucid interval was a classic deceptive sign before things got worse, and they had to operate immediately prompt surgical intervention to relieve the pressure.
Absolutely crucial management. That arterial bleed builds pressure quickly. The exam pearls are trauma causing middle meningeal artery rupture, often with the Terrian fracture, that potential lucid interval followed by rapid decline, and the lens-shaped bleed on CT.
It's chilling, isn't it? How someone can seem okay after a head injury, only for things to turn critical hours later. Really emphasizes careful monitoring.
Definitely.
Now, closely related, but with key differences, is the subdural hematoma.
Subdural, yes. The mechanism here is rupture of bridging veins, acute traumatic high-energy impact, sudden deceleration injury, or chronic mild trauma, cerebral atrophy, increased age, chronic alcohol overuse, shaken baby syndrome.
Okay, so this is bleeding under the duramater, and it's from veins, not an artery.
Correct. Those small bridging veins that cross the subdural space, connecting the brain surface to the dural sinuses, they can tear, especially with certain types of trauma or even with brain shrinkage.
And unlike the epidural, a subdural can be a slow, insidious threat, right?
Yeah.
Especially for older adults. Story about a grandmother illustrates that perfectly.
Let's hear it. Chronic subdural is common in the elderly.
Her grandchild said, "My grandmother, who is in her late 80s, started acting a bit off, slowly getting more confused and forgetful over a few weeks. That chronic presentation.
For over days to weeks.
Then she started having trouble walking. She'd had a minor bump to her head a month or so prior, nothing we thought much of at the time.
Very common history, mild trauma, often forgotten.
When we finally took her in, the immediate non-contrast head CT was diagnostic. It showed a subdural hematoma. The doctor explained that in older people with brain atrophy, even small bumps can tear those fragile bridging veins. The blood can slowly accumulate, leading to symptoms that can really mimic dementia.
Exactly. Cerebral atrophy, common in aging or chronic alcohol use, puts tension on those veins. The venous blood accumulates more slowly than arterial blood in an epidural, hence the chronic presentation sometimes.
It was a wake-up call that even a seemingly minor head injury can have serious delayed consequences, especially for the elderly. Management often required prompt surgical intervention to evacuate the hematoma.
And the key diagnostic feature on that head CT is the crescent shape of the bleed, which can cross suture lines unlike the epidural.
Right, so the exam pearls. Tearing of bridging veins, acute or chronic presentation, especially chronic in elderly alcoholics due to atrophy.
Yeah.
And that crescent shape on CT that crosses suture lines. Important distinctions.
Very important.
Okay, from hematomas, let's move to a truly dramatic event. Subarachnoid hemorrhage. SAH.
Ah, yes, subarachnoid hemorrhage. The mechanism is described as trauma, rupture of aneurysm, such as a saccular aneurysm, or arteriovenous malformation causes bleeding.
So bleeding into the subarachnoid space, the space around the brain where the cerebrospinal fluid flows.
Precisely. Most commonly, it's from a ruptured brain aneurysm, a weak spot ballooning out from an artery, or sometimes an arteriovenous malformation, or AVM. Trauma is another cause.
And this condition is known for a very specific, unforgettable symptom. Our next story captures that terrifying moment.
The thunderclap headache.
Exactly. This person wrote, "I was just sitting on the couch when it hit me. The most excruciating headache I've ever felt, like a thunderclap inside my head." That's the classic clinical presentation, isn't it?
It absolutely is. Sudden, severe onset, worst headache of my life.
It was so sudden and intense, I couldn't even stand up. I started vomiting, and my neck felt stiff as a board.
Nausea, vomiting, neutral rigidity, signs of meningeal irritation from the blood.
My husband rushed me to the emergency room. They immediately did a scan.
Immediate non-contrast head CT is the first step for diagnosis, looking for blood in the subarachnoid space.
They found bleeding around my brain, a subarachnoid hemorrhage. Later determined it was from a ruptured aneurysm. I remember them giving me a medication called nimodipine to prevent further damage.
Ah, yes, nimodipine. That's crucial management to prevent vasospasm, a dangerous narrowing of blood vessels that can happen after an SAH and cause further strokes.
It was the scariest moment of my life, but I'm so grateful they found it quickly.
It's a true neurological emergency. The exam pearl is that ruptured aneurysm leading to sudden bleeding, causing that characteristic worst headache of life. And remember, if the CT is negative, but you still strongly suspect SAH, a lumbar puncture looking for xanthochromia, yellowish CSF from blood breakdown, is key.
Got it. That headache is the critical red flag. Next, let's delve into bleeding directly within the brain tissue itself. Intraparenchymal hemorrhage.
Right, bleeding into the brain parenchyma. The mechanism here is often systemic hypertension, often in putamen of basal ganglia, thalamus, pons, cerebellum, amyloid angiopathy, arteriovenous malformation, vasculitis, neoplasm, or secondary to reperfusion injury in ischemic stroke causes bleeding.
So lots of potential causes, but high blood pressure is a big one, especially in certain brain areas.
By far the most common cause is chronic systemic hypertension. It damages small, deep, penetrating blood vessels, particularly in areas like the basal ganglia, especially the putamen, thalamus, pons, and cerebellum. Amyloid angiopathy is more common in the elderly and tends to cause more superficial lobar hemorrhages.
This sounds like a very serious event, often linked to long-term health issues, like that chronic hypertension. We heard from a listener about their father's experience.
Okay.
They said, "My dad had uncontrolled high blood pressure for years. One afternoon, he started slurring his words, and his right arm suddenly went weak."
Focal motor or sensory deficits, those are often the early clinical presentations, and they tend to worsen as the hematoma expands and puts pressure on surrounding tissue.
It got worse very quickly, and he started vomiting and complaining of a terrible headache.
Later symptoms indicating increased intracranial pressure, just like with cerebral edema.
At the hospital, the immediate non-contrast head CT was the diagnostic tool. It showed bleeding directly inside his brain, an intraparenchymal hemorrhage right in his putamen, a common location.
Yes, the putamen is a very common site for hypertensive bleeds. The CT shows a hyperdense area, bright white, right within the brain tissue.
The doctors explained that his chronic high blood pressure had weakened the tiny blood vessels over time, leading to this sudden bleed. It was a severe event. They had to work fast to relieve the pressure building up. Management included monitoring for rebleed, treating the increased ICP with mannitol, and maybe even emergency surgery.
Management is focused on controlling blood pressure carefully, managing ICP, and preventing complications. Sometimes surgical decompression is needed.
So the exam pearls. Chronic hypertension is the most common cause, leading to bleeding into deep brain regions like the basal ganglia or thalamus, causing worsening focal deficits and signs of increased ICP. And it shows up as that hyperdense area within the brain on a non-contrast head CT.
Exactly.
All right, let's explore a phenomenon that really defies simple explanation: phantom limb pain.
Phantom limb pain, a fascinating and often distressing condition. The mechanism from our text is that it most commonly follows amputation, leading to reorganization of primary somatosensory cortex and sensation of pain in a limb that is no longer present.
So the limb is gone, but the brain's map, it kind of remaps itself, and that causes pain signals.
That's the leading theory. The area of the brain's sensory cortex that used to receive signals from the missing limb doesn't just go silent. It gets taken over or reorganized by neighboring cortical areas, and this aberrant signaling is thought to generate the perception of pain seemingly coming from the limb that isn't there.
It sounds like a truly profound and often baffling experience. Here's a story from someone after a motorcycle accident.
Okay.
They shared. After my motorcycle accident, my leg had to be amputated. The physical pain of the injury was immense, of course. But then, even after it healed, I started feeling this excruciating, burning pain in my foot, the foot that wasn't there anymore.
That sensation of pain in the missing limb, often described as burning or aching or electric shock-like, that's the core clinical presentation.
It was so confusing and frustrating. How could something that wasn't there hurt so much? The doctors explained it was my brain, still processing signals and reorganizing itself, leading to what they called phantom limb pain. It's a constant, surreal reminder of what I lost. Managing it has been a journey, using pain management strategies, especially ones for neuropathic or nerve-related pain.
It really underscores that pain isn't just about signals from the body, it's heavily constructed by the brain. While specific management wasn't detailed in our source text, approaches often include medications for neuropathic pain, mirror therapy, and other techniques aimed at modulating that cortical reorganization.
So the example is that amputation triggers this cortical reorganization, leading to a persistent, often burning or aching pain sensation that feels like it's coming from the missing limb.
Precisely. It's a neurological reality not imagined.
Now, let's discuss a devastating consequence of severe trauma: diffuse axonal injury, or DAI.
Yes, DAI. This is a very serious one. The mechanism is traumatic shearing of white matter tracts during rapid deceleration of brain, for example, motor vehicle accident, causes multiple punctate hemorrhages involving white matter tracts, leading to neurologic injury, often coma or persistent vegetative state.
So it's not like a single bleed, but widespread tearing from the brain being violently shaken.
Exactly. Think of severe car crashes, shaken baby syndrome, any trauma involving rapid acceleration and deceleration. The brain moves within the skull, and the long connecting fibers, the axons in the white matter, get stretched and torn on a microscopic level across widespread areas. This disrupts communication throughout the brain.
And it can be a silent injury externally, right? But the internal impact is immense. We have a difficult story from parents about their son after a car accident.
These are always tough.
They wrote, "Our son was in a severe car accident. He wasn't bleeding externally, but he never woke up. The clinical presentation often results in devastating neurological injury. Coma or a persistent vegetative state is common."
Yes, DAI is a very common cause of coma after severe head trauma. The widespread disruption just shuts down higher brain function immediately.
The doctors explained he had something called diffuse axonal injury. They showed us on the MRI the most sensitive diagnostic modality for this, how the force of the crash had caused tiny tears throughout the white matter of his brain. Multiple punctate hemorrhages involving those white matter tracts.
MRI is much better than CT at picking up these small shearing injuries and tiny hemorrhages scattered throughout the white matter, especially at the gray-white matter junction and in the corpus callosum, or brainstem.
It was almost like the brain was shaken apart at a microscopic level. It wasn't a big visible bleed, but the widespread damage meant he went straight into a coma and has been in a persistent vegetative state ever since. It was a silent injury, but devastating. Management is primarily supportive care.
Sadly, because the damage is so widespread and involves the neurons themselves, management is mainly supportive. There's no specific fix for the torn axons.
So the example: rapid acceleration to deceleration trauma causes shearing of white matter tracts, leading to widespread brain injury, typically resulting in an immediate severe neurological impairment, like coma. An MRI is key for diagnosis, showing those characteristic punctate hemorrhages or lesions.
That sums it up well.
Okay, returning to language for a moment, let's explore a specific form called conduction aphasia.
Conduction aphasia. Interesting one. The mechanism for this is damage to the arcuate fasciculus.
Arcuate fasciculus, that's the pathway connecting the main language area.
Exactly. It's a bundle of nerve fibers connecting Wernicke's area involved in language comprehension, in the temporal lobe, and Broca's area involved in speech production in the frontal lobe. When this connection is broken, it creates a very specific language deficit.
And this type of aphasia has a fascinating, almost paradoxical presentation. Here's a story about a retired English teacher.
Oh, interesting.
Her niece wrote, "My aunt, a retired English teacher, had a minor stroke. After it, she could understand everything we said perfectly well, and she could speak fluently using complex sentences. But
Okay, so comprehension intact, fluency intact. What's the but?
if you asked her to repeat a simple phrase like, 'the cat sat on the mat,' she would struggle immensely. That clinical presentation is key. Intact comprehension and fluent speech, but a notable impairment in repetition.
The repetition difficulty. That's the hallmark.
She'd get frustrated, try different words, maybe say, 'the feline rested on the rug,' but just couldn't repeat it exactly. The doctors explained it was conduction aphasia, caused by damage to that arcuate fasciculus, the connection between her comprehension and speech centers. Diagnosis is based on that clinical assessment, specifically looking for that disproportionate difficulty with repetition. Management involves supportive care, often speech therapy.
It's baffling, isn't it? They can understand complex language, generate their own fluent speech, but can't simply repeat back what they just heard accurately. It really highlights the importance of that specific connection pathway.
So the exam pearl, damage to the arcuate fasciculus, leads to preserved comprehension and fluency, but severely impaired repetition. That's conduction aphasia.
Spot on.
And finally, on our language journey, we encounter the most severe form, global aphasia.
Global aphasia, yes, this is the most profound deficit. The mechanism is damage to both Broca, inferior frontal gyrus of frontal lobe, and Wernicke, superior temporal gyrus of temporal lobe areas.
So extensive damage affecting both major language centers.
Yeah.
And maybe the connection between them too.
Exactly. A large stroke, often involving the middle cerebral artery territory, can wipe out both Broca's and Wernicke's areas, and potentially the arcuate fasciculus as well. This leads to global aphasia.
And this condition represents an almost complete loss of language ability, as seen in this next story about an aunt after a massive stroke the nephew shared. After the massive stroke, my aunt was almost completely silent. She couldn't understand what we were saying, and she couldn't form any coherent words herself. Occasionally, she might utter a single repetitive sound like ba ba ba, but that was it.
That clinical presentation is devastating. Severely impaired comprehension and severely impaired language production. Very limited ability to understand or produce any meaningful language. Sometimes those repetitive utterances, called stereotypes, are all that remain.
It was like her entire language system had been wiped clean. The doctor said it was global aphasia, meaning the stroke had damaged all the major language centers in her brain, both Broca's and Wernicke's. Diagnosis is a clinical assessment showing those severe deficits in all aspects of language, confirmed by neuroimaging showing that extensive damage.
Yes, the clinical picture is usually quite clear, and imaging confirms the large lesion.
Management involves supportive care and intensive speech and language therapy, though realistically, recovery is often limited given the extent of the damage. It was devastating to see such a vibrant communicator lose almost all ability to interact with the world through words.
It truly is. The exam pearl for global aphasia is that extensive damage to both Broca's and Wernicke's areas results in severe impairment of both language production and comprehension. It's the most severe form.
A sobering reminder of how critical these brain regions are for our ability to connect. Okay, now let's pivot to a life-threatening condition driven by environmental factors. Heat stroke.
Heat stroke, yes, a true medical emergency. The mechanism here is the inability of body to dissipate heat, or, for example, exertion, leads to central nervous system dysfunction, confusion, rhabdomyolysis, acute kidney injury, acute respiratory distress syndrome, disseminated intravascular coagulation.
So the body's cooling system just fails,
Uh,
and the core temperature gets dangerously high.
Exactly. The body gets overwhelmed, usually by high environmental heat combined with exertion or sometimes just passive exposure in vulnerable individuals. The temperature regulation center in the hypothalamus fails, sweating might stop, and the core body temperature climbs rapidly, often above 104 or 105 degrees Fahrenheit or 40 Celsius.
And that high temperature causes widespread damage, including the brain.
Yes, the extreme heat directly damages cells and triggers systemic inflammation. The central nervous system dysfunction, confusion, delirium, seizures, coma is a defining feature, but it also causes muscle breakdown, rhabdomyolysis, kidney failure, lung injury, ARDS, and blood clotting problems, DIC.
This is an emergency that can affect anyone, but particularly relevant for athletes or people working in extreme conditions. Here's a story about a marathon runner.
Okay, exertional heat stroke is common in that scenario.
No. His friend related. My friend, a marathon runner, was competing on a scorching hot day. About halfway through, he started looking disoriented, stumbled, and then collapsed. When help reached him, he was barely responsive, his skin was hot to the touch but dry, and he was clearly confused. His temperature was over 105 degrees Fahrenheit.
That's the classic clinical presentation. Severe hyperthermia, typically 40 degrees C, plus that crucial CNS dysfunction, confusion, altered mental status. The hot, dry skin can occur if sweating stops, but skin can sometimes still be sweaty.
The paramedics immediately started hosing him down with cold water and applying ice packs.
Rapid external cooling,
Yeah.
that is paramount for management.
Yeah.
You need to lower the core temperature as quickly as possible. Cold water immersion is ideal if possible.
They explained his body's cooling system had completely shut down, leading to heat stroke, and that his brain was starting to suffer. The diagnosis is clinical, based on that severe hyperthermia and CNS dysfunction. It was a terrifying race against time to cool him down before he sustained permanent damage.
Absolutely. Time is critical to prevent organ damage and death. The exam pearl is remembering that inability to dissipate heat leads to extreme hyperthermia plus CNS dysfunction, distinguishing it from heat exhaustion or simple fever, and rapid external cooling and supportive care like IV fluids are the cornerstones of treatment.
A vital distinction. That CNS dysfunction is key. Okay, from emergencies to chronic, often debilitating pain, let's discuss migraine.
Migraine. So common, yet often misunderstood. The mechanism is described as irritation of cranial nerve, V, meninges, or blood vessels leads to release of vasoactive neuropeptides, substance P, calcitonin gene-related peptide.
So, irritation of the trigeminal nerve or the brain's coverings or blood vessels triggers chemical release.
That's the current understanding. Activation or irritation of the trigeminovascular system involving the trigeminal nerve, cranial nerve V, which supplies sensation to the face and head coverings, meninges, causes the release of these inflammatory and vasoactive substances like CGRP and substance P.
And those chemicals cause the pain.
They cause inflammation and dilation of blood vessels in the meninges, leading to the characteristic pulsating pain of a migraine. There's also a component of central sensitization, making the brain more sensitive to pain signals.
For many, migraines are way more than just a headache. They're a complete disruption of life. We have a story that vividly portrays this experience. This person shared, "For years I've suffered from migraines. It often starts with a shimmering aura, like a jagged zigzag line in my vision."
The aura, about 25–30% of migraine sufferers experience aura, usually visual disturbances, before the headache phase.
Then the most intense throbbing pain begins, usually behind my left eye. That's the typical clinical presentation, right? Unilateral pulsating headache.
Yes, typically unilateral and pulsating or throbbing in quality, though it can be bilateral.
It feels like someone is hammering inside my head and I can't stand any light. Photophobia.
Yeah.
Or sound. Phonophobia. I get so nauseous I can't keep anything down.
Photophobia, phonophobia, nausea, sometimes vomiting. Those are very common associated symptoms.
I've learned to take my sumatriptan as soon as I feel it coming on.
Triptans. They are a key acute treatment targeting serotonin receptors involved in the migraine process. CGRP antagonists are newer options too.
I also have to lie down in a dark, quiet room. The doctor explained it's due to those chemicals and nerves in my brain getting overactive. The diagnosis is primarily clinical.
Yes, based on the characteristic headache pattern and associated symptoms after ruling out other causes.
And the exam pearl is remembering that neuropeptide release, CGRP, substance P, leads to these headaches. Triptans and CGRP inhibitors are key acute treatments, while things like beta blockers, topiramate, or CGRP antibodies are used for prevention or prophylaxis, and those triggers like bright lights can help differentiate it from other headache types sometimes.
Well summarized.
And finally, let's explore a progressive neurodegenerative disorder, Parkinson's disease.
Parkinson's disease, a condition many are familiar with, at least by name. The mechanism for Parkinson's disease is loss of dopaminergic neurons of substantia nigra pars compacta.
Okay, so specific brain cells are lost. Cells that make dopamine, in a region called the substantia nigra.
Exactly. Deep in the midbrain, there's an area called the substantia nigra pars compacta. The neurons there produce the neurotransmitter dopamine, which is absolutely crucial for smooth, coordinated muscle movement, part of the basal ganglia circuits. In Parkinson's, these specific dopamine-producing neurons progressively degenerate and die off.
And the loss of dopamine leads to the movement problems we associate with Parkinson's.
Precisely. Reduced dopamine levels in the basal ganglia disrupt the brain circuits that control movement, leading to the characteristic motor symptoms.
This is a condition that often begins subtly, but its progression profoundly impacts daily life. We hear about a father's journey with Parkinson's.
Okay.
His child told us, "My father started developing a slight tremor in his right hand, a subtle pill-rolling movement, especially when he was resting."
The resting tremor, that's one of the classic cardinal signs, often starting in one limb. Part of the TRAP acronym. Tremor, resting, rigidity, akinesia, bradykinesia, postural instability.
Then, his movements became slower, bradykinesia. His face seemed less expressive, hypomania, and his handwriting got tiny micrographia.
Yes, slowness of movement, bradykinesia, or lack of movement, akinesia, is another core feature. The reduced facial expression and small handwriting are common manifestations.
He started shuffling his feet when he walked and had trouble turning around, signs of postural instability, which usually comes later.
Right. The postural instability leading to balance problems and falls tends to emerge as the disease progresses.
The doctor diagnosed him with Parkinson's disease, explaining about the loss of those dopamine cells in the substantia nigra. The diagnosis is primarily clinical based on these signs.
It is mainly a clinical diagnosis based on finding bradykinesia plus either tremor or rigidity. There's no definitive blood test or standard brain scan.
It was a tough diagnosis, but the medication, especially the levodopa, made a noticeable difference in his ability to move more freely and maintain his independence.
Levodopa, often combined with carbidopa, is the cornerstone of management for motor symptoms. It's a precursor to dopamine that can cross the blood-brain barrier and get converted to dopamine in the brain, helping to replenish the deficient supply.
So the exam pearl. Loss of those dopaminergic neurons in the substantia nigra pars compacta leads to the TRAP symptoms. Levodopa-carbidopa is the first-line treatment for motor issues, and pathologically, finding those intracellular protein clumps called Lewy bodies is a key histological feature post-mortem.
Exactly. That sums up the key points for Parkinson's.
Wow, what a deep dive that was into the brain's incredible complexity and its vulnerability, too.
It really is incredible, from subtle eye movements like in Parinaud to devastating hemorrhages, phantom sensations that feel so real, to the profound challenges of language and movement.
Yeah, each story truly brought these conditions to life, didn't it? Beyond just the mechanisms.
Absolutely. By linking these precise neurological mechanisms, a lesion here, a blocked artery there, missing cells, chemical imbalances to the lived experience, we gain not just knowledge, but hopefully empathy. Right. And a deeper appreciation for that intricate balance within our nervous system. It just highlights how a tiny disruption can ripple through an entire person's world.
Exactly. So what does this all mean for you listening? Well, maybe the next time you observe a seemingly small change in someone, a difficulty finding a word, an unusual tremor, maybe a sudden shift in how they move or behave, you might now have a deeper framework, a better understanding of the complex, often hidden processes that could be at play. This journey through these conditions really reminds us just how interconnected our bodies and minds truly are.
Indeed.
Thank you so much for joining us on this deep dive into the fascinating and sometimes challenging world of neurology. Keep that curiosity alive, keep asking questions,
And keep learning.
and we'll see you next time.